morning. This is section 2 of the community resiliency model. We're starting with skill 2, conversational resourcing. We ended our last session with identifying our resources. So we're going to go now is talk about some of the other kinds of ways to use resourcing. And we're going to talk about using resources after a crisis, after a loss, or if someone mentions what we might think of as a questionable resource. So first of all, after a crisis, what we've found is important is to have a resiliency focus. So we may ask, can you tell me the moment that you knew you had survived? Can you tell me the moment help arrived? Who or what is helping you the most right now? So the idea is to find out what else is true besides the survival story, because this becomes another part of the story that is about how they're getting through and how they're going forward. Well, like, what's helping you the most has been one of the most important questions that I've asked as I've been to so many disasters around the world in the last 10 years. So the second one is loss. As many times when people have lost someone beloved to them, and it can be a person or a pet, sometimes people around them have difficulty hearing what they have to say. So what we have found is important is to ask about them. Is that, can you tell me your meaningful memories of him or her for you to call them up as a resource? What is it about them that you loved? And what did you like to do together? And what kind of words of encouragement would he or she or they have said to you during difficult times? And then the next one is questionable resource. And this is a little tougher because this may be something that we don't want to reinforce. We're saying, oh my goodness, you've been an alcoholic and a drug addict, and you're saying that you know, Jack Daniels is your resource. Do we really want to reinforce that? The one thing that I would suggest to you is you might want to hear why it's a resource, because many times people will use almost anything, right, in order to get back into their zone. And so you might want to not skirt away from it too quickly, but you want to, of course, expand the resources. But I think one calls to mind is sometimes people will say, I've heard from a person who's been sex trafficked, well, it was the person who trafficked her. And the reason why she said it was because it was the first time in her life that she had 3 square meals, had a roof over her head. So really the resource was about feeling safer physically, and that he was connected to that. So I think as we sometimes explore the reason why people call up a resource, we may find out more information that can help us to help them expand their resources. So not to run away from those too quickly. But I think the other thing we've learned about resourcing, it doesn't have to be shared with people in like a menu-like way. It can be a conversation. So oftentimes when we have a friend or a colleague, we may say, oh my goodness, this is really a hard time for you right now. And I'm just wondering, you know, like in the past, what kinds of things have helped you get through things like what you're experiencing today? And this is a way that can actually help them pop up in their own mind ways that they've coped with past stressful events or traumatic events. And even asking the question, you know, what helps calm you or uplifts you when you have difficult times? And people then can come up with the most amazing things during the most difficult situation. And this I want to also say, we're also still wanting to be respectful to whatever stress is happening to them, but in a conversational way, asking them other aspects of what also could be true about what's happening to them. And this brings me to our next section, which is why a biological model like CRM. And many years ago, when I was working as a teacher of family medicine, I read the Adverse Childhood Experiences study. And I was thinking about ways to teach my family practice residents about the impact of trauma and traumatic stress injury on the patients that they were having in the clinic. And when I read this, you know, it was the largest study, first of all, of its kind ever done to examine the health and social effects of adverse childhood experiences. The fact that it was initiated by Dr. Folletti and Dr. Anda, Dr. Folletti working at Kaiser Permanente in San Diego, and Dr. Anda from the Center for Disease Control in Atlanta, it was being brought into the public health field, which was so important. And now, you know, I go around the world, I say, have you heard of ACEs? Most people now have heard about ACEs. And so the first study was done with over 17,000 people. And what they did is they asked a simple question of whether or not before the age of 18, they'd ever experienced one of these adverse childhood experiences. You can see the categories of abuse, neglect, household dysfunction. And if they had one, if it happened to them once, they got a point of 1. So then what they did is they looked at the charts of the patients. And they wanted to see if there was a correlation between adverse childhood experiences and health outcomes. And boy, did they learn a lot. And what they found is if you had 4 or more adverse childhood experiences, that your chances of developing diabetes, coronary artery disease, chronic pulmonary disease, and also autoimmune diseases, and having what we would say mental health challenges were much higher compared to those with 0. But um, if you had 6 or more, that your lifespan was cut short by 20 years compared to those who had 0, and your chances of being an IV drug abuser, I believe that the number was 4,600% higher chance than those who had 0. So that really prompted me to start thinking, even in the creation of this model, what's happening to folks with adverse childhood experiences? Are they in their high or their low zone? And if they're in their high and low zone, what is happening to the physiology of the human body? And if that starts getting set in childhood, what can we do as a model to possibly help to reset that? And what if we taught wellness skills to help people get into their resilient zone? And could that possibly reduce the effects of adverse childhood experiences? So of course, theoretically, we're saying, we think so. And this is why it's important to not only invest in cognitive or thinking models of changing the way we think about our stress and our traumas, but also to invest in paying attention to the human nervous system and how we can start to read the nervous system that we've already talked about through tracking in order to change the experience. So here are some the other things that we've already mentioned, but I think the next slide is one of the most important ones, is that what are commonly viewed as behavioral or public health problems are often personal efforts to cope with adverse childhood experiences. And this is why it's so important that that question about what happened to you in terms of the trauma-informed world we're trying to create, but also we're trying to also start thinking about resiliency informed. And I'll talk a little bit more about that in a second. But what we've learned, as if you've been counting out your aces as you've been listening to me, adversity is not destiny. And I first heard this term when I was up in Montana, and from my friend Dana Eisenberg, who was a trainer for an ACEs initiative they had up there. And I thought, this is what we have to remember, because as human beings, and because we know now through neuroplasticity that the brain can change, and that neurons that fire together, wire together, that if we pay attention to our well-being, could that reduce the impact? And what if we could teach everyone we know how to read the nervous system, and how could that change the world? And so then I read Christina Bethel's study, and I got so excited because she's from Johns Hopkins, and she was investigating the associations between the ACEs scores and factors affecting children. And what she found was that resilience was defined as staying calm and in control when faced with a challenge. And for children, ages 6 to 17, staying calm and in control when faced with a challenge reduced the negative impact of adverse childhood experiences. And there were higher rates of school engagement among children with adverse childhood experiences who demonstrated resilience. So this to me was, oh my, this is it. We know that every child isn't necessarily born with a nervous system that they can stay naturally calm. But what if we taught children skills so that they can access their innate, elegant design of the human nervous system to be in their zone of well-being? So that's what's exciting about this kind of research, and also exciting as possibly the community resiliency model being one of the antidotes to what happens to us if we have childhood adverse experiences. And so this leads us to my most favorite slide, like Oprah's favorite things, is to, I've been at many ACEs conferences where often they talk about conventional thinking. People are bad, people need to be punished, what's wrong with you? And then of course the trauma-informed conversation that's been exciting, saying people are suffering, we need to know that people really do care, but they lack the skills, and we need to learn how trauma has impacted a child and adult's life, and we need to ask that most important question about what happened to you. But then we're saying in the community resiliency model that we want to ask about, yes, not only what happened to you, but what's right with you? What are your strengths? People are resilient. They need our compassion as they learn new skills. And we've seen that people can learn new skills, and that when they learn new skills, they can start to reduce their own experience of suffering, and it stays with them. And so that's what we want to invest our time in the Trauma Resource Institute, is how can we create not only trauma-informed communities, but resiliency-informed communities. And that brings us to, we have to have a working definition of what is trauma. And for us, trauma and stress is too much too fast. And perception is the key. And that means it could be a car accident, it could be somebody bullying you on the schoolyard, it could be an earthquake, it could be the things that happen to us that we don't expect, and that it dysregulates our nervous system and bumps us into the higher low zone. And then it can also be what we call toxic stress. Some people call this developmental trauma, and that's too little or too much for too long. And that could be childhood neglect, that could be poverty, racism, the microaggressions that happen when people are felt to be the other, which leads us to the next way we describe it, which is, again, perception is everything. And this is a little, I did not slap you, I high-fived your face, but if you perceived it as a slap, then your nervous system would have become dysregulated. And what I might be afraid of, or what might threaten me, may not threaten you. And that's why we have used this concept of big T, little t, and cumulative C trauma. And big T and little t trauma I borrowed from the work of Francine Shapiro, and we added to it. But basically that's the kind, big T trauma are like acts of violence, war, the things we consider as big T traumatic events. I'm not going to read every single one, but little t trauma is perceived by the person as a big T, but sometimes society or our family says, oh, that was just your tonsils taken out, it was no big deal. But sometimes routine surgery, dog bites, the different things that you'll see on this list have been experienced by the person as a big T trauma, because, as we've said, perception is everything. And then finally, cumulative trauma. And cumulative trauma includes racism, poverty, homophobia, transphobia, bullying. And, you can look at the list. We worked with Native peoples, historical trauma, immigration challenges for people that are in our refugee population. But in any event, these kinds of cumulative traumas coupled with little t traumas and big T traumas are like the perfect storm of the nervous system. So it's important for us when we say to someone, oh, have you ever had a trauma? A person may not think the fact that they've lived in poverty or dealing with racism is a trauma, but the nervous system may experience it as such, because the nervous system goes into the higher low zone when the person feels threatened. And that's why we think the languaging and the paradigm shift is so important. We need to start talking about what happens to us biologically, not just what only happens to our thinking, but also happens to our body, because our body's regulation affects our thinking. And we'll talk more about that in a little bit. And so before I do that, I want to talk about the third skill, which is called grounding. And grounding is basically the direct contact of the body or part of the body with something that provides support in the present moment. So with grounding, we can ground standing, sitting in a chair. We can ground with a hand. If I put my hand on my table and I can feel the hardness and the coolness of the table, I come into the present moment. Grounding is important because when we are in that present moment, we're not thinking about the past or the many things I have to do in the future. We're right here in the here and the now. And we also have learned to give choice, because not everybody grounds sitting in a chair, and some people have been tortured in chairs. But also we have learned that sometimes people need something heavy on their lap or on their feet, because they may always have the sense that they're floating. And so sometimes a purse, a backpack, a weighted blanket, a weighted pillow can make the person feel they're more in the present now, in the present moment. Because what we learned about the whole aspect of grounding is some people feel like they're in a constant state of movement. They don't have what's called gravitational security. And that's one of the reasons why it's so important to ground.